Good morning, everyone. I'm Jason Resendez, President and CEO of the National Alliance for Caregiving, and I'm excited to welcome you to this forum on behalf of the National Alliance. Family caregivers, as I'm sure all of you understand, are the cornerstone of our healthcare system. And nowhere is this more true or more consequential than in transplant care. And that's why we're here today. Next slide. For those of you who may be new to us, NAC, or the National Alliance for Caregiving, has spent 30 years as a national catalyst for change, transforming how our country recognizes, supports, and values the contributions of our nation's family caregivers. For 29 of those years, we've partnered with AARP on the Caregiving in the U.S. data project, which gives us a definitive picture of caregiving in America. And we do this work alongside more than 40 member organizations and hundreds of subject matter experts and advocates across the country, many of whom you'll hear from today. Our work is organized around three priorities: championing caregiver health and wellness, putting caregivers' own physical and mental health on the national agenda, driving economic inclusion, confronting the financial toll of caregiving through policy and workplace change, and fostering caregiver-friendly communities so family caregivers can thrive where they live. Next slide. And we do this work because of the scale of the challenge before us. And let's start with those numbers because it really tells a remarkable story. Today, more than 63 million Americans are family caregivers providing ongoing, demanding care for someone in their life. That's roughly 1 in 4 adults. And that number has grown by nearly 50% since 2015. Together, they provide over $1 trillion in care every year, according to our friends at AARP, averaging more than 27 hours of care each week. And they carry real hardship while doing it. Nearly a third are sandwich caregivers, caring for children and adults at the same time, and almost half report negative financial impacts from their caregiving role. 63 million people, $1 trillion in care. This isn't a niche issue. This is a shared challenge and infrastructure. Next slide. And I mean that literally. Family caregivers are essential to our healthcare system. More than half of family caregivers, roughly 32 million people, are performing medical and nursing tasks. Think injections, wound care, tube feedings, monitoring vitals, managing medical equipment. Yet only about 1 in 5 receives any training for these clinical tasks. And here's what should give us hope. Among those who are trained, 96% say it prepared them well and gave them confidence, more confidence in providing their caregiving roles. Training works. We aren't just providing it and prioritizing it. Caregivers are also our health system's navigators. 70% monitor the severity of their loved one's conditions. Nearly two-thirds communicate directly with healthcare professionals. Almost 6 in 10 advocate with providers and agencies on behalf of their care partners. And these responsibilities don't fall evenly. Women, and particularly women of color, shoulder medical and nursing tasks at the highest rates. Now, take everything that I've just described and intensify it. That's transplant caregiving. In transplant care, the caregiver isn't just helpful, their presence is often a prerequisite for a patient to receive a transplant at all. We ask caregivers to coordinate care, master complex medical regimens, provide round-the-clock support, sometimes 24 hours a day for 100 days. We make them a condition of this life-saving treatment and care, yet we have not built the infrastructure needed to support them. But this is why this moment matters. Change is happening. Federal reform efforts are shaping the transplant system. New Medicare billing codes now allow providers to be reimbursed for training and identifying family caregivers. And through our Transplant Caregiving project, we now have a national data understanding of exactly where the gaps are and where the opportunities lie. And there are amazing experts like the ones you'll hear from today who are doing work in systems and research institutions to help us better understand how to better support and address the needs of transplant caregivers. And the question before us today is whether we'll seize this moment, whether caregivers will finally be recognized as what they have always been, essential partners in care. And change happens through conversations like today, and that's why I'm hopeful. And through the work of system leaders you will hear from and from you, the family caregivers and advocates, industry leaders and experts who take this knowledge and have the opportunity to take it back to create change in the communities and health systems where you live and work. So thank you for being part of that change with us and for your part in recognizing and elevating the critical role that family caregivers play in our society and particularly in our healthcare system. And with that, I'll turn it over to my colleague Yadira Montoya to start the program.
Good morning, everyone, and thank you, Jason. So before we get started, I want to share a quick logistical note. So we've included a couple of polls throughout today's session, and those will appear automatically in your screen. And we've also drafted some questions and reflections that I'll share with you, and I'll ask you to respond to in the chat as we go. For today, I'll begin with a brief overview of NAC's research, and then we're going to move on to our panel discussion. And we do have some time for Q&A at the end. So if you hear something that resonates with you, or if there's a question that comes up, please use our Q&A feature so that we can answer it at the end of the session. And to start us off, I want to get a sense of who is in the room. And so our poll question is, if you can pull that up, Mike, please, is which best describes your primary role or organization? And if none of the responses that we've provided kind of correspond to your role or organization, feel free to add it in the chat. If your response is other, feel free to add it in the chat. So I'll give it a minute or so. Okay. As we're waiting for the results on the poll, I'll read some of the things that I'm seeing in the chat. So thank you so much. So advocacy organization, both for caregiving and lived experience. Thank you. Also nonprofit in South Dakota. Thank you for working to implement caregiver support programs in rural communities. Okay. So it looks like, thank you all for responding to the poll. And it looks like the majority of you are joining us from a transplant center. Or actually, excuse me, I didn't look at the response options far enough, but the most of you are joining us are people with family caregivers or people with lived experience, followed by patient caregiver organizations and or transplant centers. So those are our top three. Thank you so much for responding to that. So I'm going to close the poll and thanks for doing that. Okay, let's keep on going. So before I talk about NAC's research and set up for a conversation with our panelists, I wanted to start off by talking about why caregivers matter so much in transplantation. Jason has already done that for me, so I won't belabor the point. But I think the one thing I do want to mention here is that we see that caregiving is critical across the healthcare system. Again, in transplantation is different and unique because patients are often required to identify a family caregiver. So caregivers really influence whether someone is eligible for a transplant and then become essential partners throughout the entire experience. And at the same time, we see that there's not a lot of caregiving support available for caregivers to sustain themselves, to do the work that they are being expected to do. And that disconnect is precisely the point of our research and our work. So, if caregivers play such a critical role in transplantation, how are centers identifying, assessing, and supporting their needs? And so, throughout my presentation, I'll share what we've learned when we survey transplant centers across the country. And then I'll be inviting the panelists to reflect and share how these findings compare to some of the work that they're doing on the ground in their clinical practices, as well as what they're seeing in research. Next slide. So to start us off, back in 2022, NAC launched a project to better understand the needs and challenges facing transplant caregivers. Over the last several years, that work has really evolved into a series of reports, forums, and partnerships designed to better understand the caregiver experiences and identify promising practices across the field. These efforts have culminated in the creation of the Transplant Caregiving Collaborative. And the collaborative itself brings together clinicians, researchers, patient advocacy organizations, caregivers, and industry partners to understand and address this central question. How do we move from transplant caregiving support? How do we make caregiver support become more routine and consistent part of transplant care nationwide? And the panelists who have joined us today have helped advance that conversation through, again, their clinical care and their research. Next slide. So in terms of table setting a little bit, the purpose of a survey we conducted a few years ago was to understand the policies and practices of transplant centers in identifying, assessing, and providing support for family caregivers across the country. In the survey, we included the responses of 114 unique transplant centers across the U.S. And here you see the breakdown of the respondents who fielded the survey or answered the survey. One of the first things that we noticed was the tremendous variation in how caregiver support was organized. And so a little bit of a sidebar, we defined caregiver support program as something that was structured, planned, and coordinated activities within routine transplant center care that were specifically designed to support family caregivers. These programs could help both the caregiver and the recipient, but we were really interested in the programs that really allowed for that really focused on the caregivers being able to sustain themselves, to maintain their own health and well-being, and we were also looking at programs that were offered broadly or for specific transplant populations. At some of these centers, the support programs had dedicated leadership. Others, the responsibility of providing these services were shared among nurses, social workers, psychologists, and transplant coordinators. And so while that flexibility really allows for innovation, it also means that caregiver support often depends on local resources, staffing, and institutional priorities. So as you listen to today's panel discussion, you'll hear examples from pediatric, adult, solid organ, blood and marrow transplant contexts. Next slide. Next slide. One of the strongest data points from our research was the inconsistency of caregiver support. So we learned that only 58% of the centers reported having a written process for assessing caregiver support needs. And perhaps the most important question is, what are caregivers being assessed for? So in transplantation, we found that caregiver assessments often were tied to the caregiver's eligibility and readiness, and centers wanted and needed to know whether a caregiver was there to support the transplant process and the transplant recipient, which is really important. However, these findings also point to the fact that the focus on the caregiver is whether they're able to perform the task, not whether they need support to perform those tasks. And that distinction is really important. If we don't understand what caregivers' capacity needs are, then the medical information that is provided to them can only support them so much. And so during the panel, we'll explore how different organizations identify caregiver needs and kind of whether current assessment approaches truly reflect caregivers' experience across the transplant journey. Next slide. We also asked about specific assessment topics and learned that most centers focus on responsibilities directly tied to patient care. So areas like symptom management, medication administration, emergency response, and understanding the medical aspects, the medical procedures were those that were assessed more frequently. And again, these are critical skills, but what appears less frequently are issues like the caregiver's mental health, the caregiver's health and well-being, issues of family dynamics and relationships, and health-related social needs like housing, transportation, etc. In other words, transplant centers are often assessing for whether caregivers can provide care, but less frequently assessing what caregivers need to provide that care again and how providing that care is affecting them emotionally, physically, and financially. And that raises a really important question today for today's panel, and I would say all of us, is how can transplant centers better balance this patient-centered requirements and provide the caregiver support? Next slide. We also looked at when caregivers were being screened, and this finding generated a great deal of discussion. So most assessments occur at key clinical milestones, like in the waiting list and solid organ, during hospitalization, the surgery, or during discharge. But only about 3% of the centers reported assessing caregiver circumstances at regular intervals, so 3%. That means that many caregivers were evaluated at the beginning of their journey, but not necessarily throughout it. And we know that caregiver needs really involved. And so what a caregiver needs and a patient needs before transplantation may look very, very differently from what they need during recovery or years later. Next slide. Next slide. While there were some challenges, our findings also highlighted important progress. So most transplant centers, 70% in fact, report offering some form of caregiver support program as part of their care delivery. However, that availability doesn't necessarily mean consistency. Services really varied widely in scope and intensity, and here in the table you see the types of programs that were available. Some centers offered psychosocial services, others education programs, peer mentoring, financial counseling, etc. And another important factor to mention here is that we also asked about delivery site and that learned that a lot of these support services are also being outsourced, whether it is to the transplant center's healthcare system wide or to a third party. So that result really means that caregiver access can really depend heavily on that. We need a better sense of how caregivers are accessing those services. We know that every time there is a referral that there could be a potential for a lack of follow-up or for many reasons. Next slide. We also asked about caregiver-specific education and training, and we learned that just over half of the transplant centers are providing caregiver-specific education and training, and that then that means that on the flip side, the other half, nearly half, don't provide it or are unsure that it exists. This is particularly important because, again, caregivers are routinely expected to perform highly complex medical and care coordination tasks, yet the education and training is not necessarily being provided consistently. And as I mentioned earlier, or as James had mentioned earlier in the forum, we know that caregivers are managing complex medications, monitoring vital symptoms, making healthcare decisions, and coordinating across multiple providers and specialists and responding to emergencies. And so without this proper information, education, it really begs to differ how our family caregivers and finding this accurate, reliable information, and how is not having this information impacting their decisions and support that they can provide. Next slide. We also looked at when education, these are the most common topics of education that were provided. They're focused on the clinical responsibilities, medical procedures, symptom management, and understanding the recipient's condition. Again, essential topics, but what we see less are opportunities around the caregiver, sustaining the caregiver, addressing stress, navigating the healthcare system, dealing with employment challenges, financial stress, and family dynamics. So these topics really raise another important question. If we want caregivers to thrive, patients and caregivers to thrive throughout the transplant journey, are we also teaching them how to care for, why are we only, excuse me, uh, are we teaching them only to care for the transplant recipient, or are we also helping them sustain themselves? Next slide. And then another notable finding in terms of education is we asked how, uh, when that education is provided, is it provided alongside the patient or separately? And there are certainly benefits to joint education. It promotes a shared understanding. It can strengthen communication between the recipients, the caregivers, and of course the providers. And at the same time, caregivers can also have concerns they may not feel comfortable discussing in front of their care recipient. Questions about stress, burnout, capacity, role expectations, emotional exhaustion, etc. So these findings lead us to ask whether transplant centers should think differently about caregiver-specific education. Next slide. And the final finding I'd like to highlight concerns barriers. So perhaps most surprisingly to us was the reported challenge of not providing caregiver support was not around staffing or reimbursement or resources. It was limited awareness of the needs for caregiver support. Now, this tells us that awareness itself remains a barrier, and while caregivers are essential to transplant success, their needs may not always be seen as requiring dedicated attention. So we also see the financial limitations, workforce constraints, competing demands, et cetera, as a barrier to providing these caregiver support services. But here is where I am going to transition into our panel and hear about caregiver support. So beyond identifying gaps, what we want to understand solutions, what models have worked, what evidence supports caregiver support programs, and what investments are needed to move the field forward. And so with that, I want to introduce the first question for the chat, and it is, what, if anything, surprised you the most about the availability of caregiver support in transplantation? You can move on to the next slide. It is the QR codes for all of the research. I took some data points that I wanted to highlight, but there's so much more information there. Thank you for adding those to the chat, Lauren. Yeah. Okay. So as you think about this question, and the question about is what surprised you the most about the availability of caregiver support transplantation, I'll keep us moving along to today's because the most important part of our session, which is with a conversation with the panelist. So, yeah. So today we are joined by an outstanding panel whose work spans research, pediatric, transplantation, young adults, and caregiver support innovation. And so you can find their full bios of Dr. Priscilla Badia, Dr. Nicole Haiti, and Camila Nontera in the webinar materials. But this morning we're going to keep things conversational and move straight to the discussion. Then I'll call out. Great. Thank you for those comments around kind of what surprised you the most. Thank you. So let's get started with our panel. And I'd like to invite each of our panelists to briefly introduce themselves and tell us about the patients, caregivers, and the communities they serve. So let's start with you, Camila.
Hi, my name is Dr. Camilla Nontra. I am a psychologist, counseling psychologist by training. A lot of my focus is on transplant, and I apologize that my voice is raspy right now. Um, so a lot of my focus is on the psychosocial aspects of transplantation. Um, and I'm interested in things such as why do we see some differences in terms of transplant outcomes, um, needs in terms of um, health behaviors. Why do we see mental health? How do we assess mental health in transplants, as well as a number of other outcomes? And so that is my primary focus. So I'm a psychologist by training, and so my experience is going to be a little different than the transplant professionals, that are on the panel.
Thank you so much for bringing that research lens. Nicole, can we hear from you next?
Sure. My name is Nicole Haid. I am a pediatric transplant nephrologist. So I care for children who require kidney transplants and who have received kidney transplants. I work in the Bronx, and I I take care of patients up to 21 years of age. And so, you know, dealing with a wide range of needs in terms of the care that they require. Obviously, because they're pediatric, their parental involvement is going to be high, maybe transitioning off when they reach 21, when they're transitioned to the adult side. And I would say the focus is working in my patients' population is working with the parents to care for the child. And then as they get older, working primarily with the young adult as they start to take over their needs and figuring out what their unique needs are, which we can talk about as we do more discussion in the panel.
Awesome. Thank you. And that transition from like pediatric to adult is one that family caregivers talk to us a lot about seeing differences in the supports available. So thank you. Priscilla?
Hi, everybody, and thank you for having me here today. I'm Priscilla. I'm a pediatric bone marrow transplant doctor at Cincinnati Children's. And around 2 years ago, we started the Engraft Learning Network, which is a group of pediatric and adult centers all around the US, focused on improving patient outcomes. And this is through patient and caregiver engagement. And so in this network, patients and caregivers are part of our uh, research, are part of our programs, are part of our decision making. And so I hope to share more with you about this on how that we found is the key for, for changing things, for improving outcomes, from understanding better what's really happening and what we as physicians don't really see in the day to day. So thank you for having me here today.
Of course, it's a pleasure to have you, well, all of the panelists, and then also think really appreciated your comment around involving those most impacted in the solution. So I appreciate that. Um, so moving on to the second question, our findings showed tremendous variation across transplant centers, and I'd love to understand a little bit more about what motivated each of your work. And so the question is, what prompted the development of your caregiver support program model or area of research? And would love to hear both from like the clinical and the research perspective, kind of what are the unmet needs? the evidence, the data, and observation that drove the creation of the programs that you all lead, whether in clinical or in research. So, Nicole, did you want to get us started?
Sure. So, I'm the medical director for the pediatric kidney transplant program, and I would say that clinical experience was probably the a big driver. When you're young and you're just starting out, you you're more concrete in your thinking. And so you have a script that you develop, but then you realize that it doesn't work, right? Because at the end of the day, what I want is not just to transplant patients, but I want them to have successful outcomes. And the successful outcome is not just limited to whether or not they take their meds and keep their graft, but whether they are in school and they're thriving and they're developing and all of these different things. And what I realized was that that script that I may have had in my head did not work for each patient. And and when I say, and sorry, for pediatrics, when we say patient, we mean the entire family.
Mhm.
Because sometimes people think, well, the 5-year-old can't, contribute to their care in that kind of a way. But so when we speak to both the parent and the patient, and we realize that it's a partnership. So what we had to do was realize that what worked for some patients didn't work for other patients in getting them ready for transplant. I'll start with that. Some patients needed a lot more intense education, special sessions, a lot of work. Other patients, it was more smooth. And respecting that, because we realize that everybody comes from, different levels of understanding. And then going on, realizing through either poor outcomes or just based on what the parents shared with us, that we had to develop unique I'm trying to find the right word, unique paths and unique ways to ensure the success and to support them. I know I have limited time, so I'll let others talk, and then hopefully I can go into more detail about what that looks like.
Thank you, Nicole. I think what really stands out is the meeting patients and families where they are at, and another recognition of people and families outside of the medical room and what helps them thrive and what's important, in general in life, family, fun activities, quality of life, those types of things. So thank you. Priscilla, did you want to go next? What prompted the development of the Caregivers program or model? And I recognize that you have examples both from your work at the Cincinnati Hospital and then in Graph. So
Yeah,
however,
so
I answer that.
so I think you start hearing from different families, or maybe we've had some families that were a little bit more vocal, or some social workers that identify these huge barriers in certain populations. And so research-wise, we've done a series of like interviews to different patients and caregivers from like pediatrics to adult, young adult. And so that has been very helpful for us, kind of getting what you're saying, that I think it's important, and what you showed, Yadira, was really good, like looking at the numbers and the percentages. And so we have done 2 studies now, interviewing patients and caregivers and looking at the numbers and looking at where the needs are and are we meeting their needs, right? Because I think we as physicians, as Nicole was saying, we have a priority, which is their function, but that's not the most important, right? We want kids to go back to school, people to go back to work. And so research-wise, we have done these interviews and we found very interesting results that now we're working on. As you mentioned, one of them was mental health. And so we're finding resources, barriers, financial needs, etc., that then in the ENGRAF Learning Network, we're trying to see how we can standardize and make all this education and resources a little bit more available, regardless of where you're at or where you come from. And so I think it's a learning process. I think it's a lot of education from both sides, but I think this involvement of the patients and caregivers from the start has been good in decreasing these barriers. So I think there's a lot more work to do, but I think starting to think as research, as you're pointing it out, it's very important.
Yeah, of course. And what an excellent segue to you, Camilla, both in the sense of your focus on the psychosocial aspects of kind of end-stage organ disease and transplantation, and then the mental health needs of individuals and families. So can you tell us a little bit more about your research and what drove you to focus on this specific topics?
So the initial drive into this area was when, so I'm a member of the psychosocial and ethics community of practice of the American Society of Transplantation. And this is a group, as you can tell by the name, is very much focused on psychosocial needs, also ethical concerns. And so we had this initiative to try to understand the needs of caregivers and what can we see in terms of the research, right? Because the research in this area is extremely limited. Um, and so being able to see that there's this connection regardless of organ type in terms of some of the caregiver burdens, looking at whether it's financial concerns, looking at mental health needs, how are they adjusting, right? And then also, um, caregivers also see some benefits, right? So as much as we think of the the negative sides, there are also a lot of positive sides to um, the experience of being a transplant caregiver, being able to see your loved one a lot of the time, being able to see them improve their quality of life, being an integral part of their recovery. Um, and so that is what kind of drove this direction in terms of my research. And it's as Nicole mentioned earlier, one of the important things is that given that there's so many limited examples of good ways in which we are assessing and looking at caregiver needs, it's important for us to focus on the good examples that we have, right? I saw in the chat that somebody had mentioned Rush University is doing some really good work, and so being able to look at some of those and learn from them would be really important.
Thank you for that. And thank you for highlighting the positive aspects of caregiving that we tend to focus less on because there are some positive aspects. And in our work at NAC, we often hear like, I'm willing and able to step up for my family member if it just wasn't so hard, if there was systems in place that can help me do that. So really appreciate you pointing that out. Okay, so moving on to the next question. On our end, we found that only 58% of the centers have a written process to assess caregiver needs. And I'm curious about how your individual organizations go about identifying and assessing caregiver needs. And so if you want to get us started, Priscilla, that would be great.
Yeah, so specifically in Cincinnati Children's, and I think it's important to notice that, we find that everybody has different resources, and I think one of them is the social workers, which I think they do a fabulous job. And so right now, what we have changed is that we are trying to make this more of a multidisciplinary approach. And so as much as we can, whenever we meet a new family, we try to all go in as a group for like an initial visit. And so we don't have and I'm sure this is a problem that we would try to fix, right? Like we don't have as many social workers or psychologists as we would like to have. And so, but we think that meeting a new patient or family in the first visit, all as a group, it's really important because then you don't have to, right? Like it's not like, oh, he told me, they told me, I didn't get this piece of information. So all the information is there at the same time as a group. And so for the first visit, we try to save more time to meet these families together to make sure that we're all in the same page. We are aware of everything that's happening. And many times the families are not going to share the same thing to the physician and to a social worker. So we're trying to encourage and empower even patients and families to feel that we are all the same in that room and that we can bring up, any concerns, even if it's childcare for another kid in the family, to financial, to medical problems. And then the social workers, they do a fabulous job checking in with the families often. Um, Unfortunately, this is not available in every center, so I think that's something that we struggle with. But I think that's our first point of contact with the families, to look at barriers, to look at needs, and to try to work on them since the beginning. And I think important to mention, we need to check in later again, right? Like at the beginning, there's so much going on, we're overwhelmed, and there might not be things that we catch on. And so checking in routinely, it's also an important part of the process that we have established.
What about at your center, your transplant center, Nicole?
Yeah, so I would say that it starts pre-transplant, when our patients do their transplant evaluation. That is a required part. I mean, it's required dated by CMS, but it's also
Mhm.
just a standard part because we also have psychology see them, and that's actually not mandated. But so they see both the social worker and the psychologist in the pre-transplant. They're also, and it's not just, are you taking your meds? Do you come to appointments? But they learn about the family structure. They learn about their belief system, because there's some belief systems that, if you don't believe in traditional medicine or something like that, that may impact the way that we're able to care for our patients. And then, like Priscilla said, I think it has to be an ongoing assessment because things change even in the post-transplant setting. So yeah, they're 10 years post-transplant, but like one of the reasons why I was a little late today is because one of the patients came and long story short, they need housing and the patient and the father, the mother passed away like several years ago, are living in a different household because they can't be in the same house right now. There's no space. And so, we know this because we ask, like, we've been trying, they don't come to clinic. We don't just say, oh, you don't come to clinic. Well, you're not doing what you're supposed to do. We call repeatedly and try to figure out how can we help you and then talk to them privately. So it's, just an ongoing. And I think if I had to summarize in, a few sentences, I would say that the best way that we're able to deliver that care and have them trust us, because like Priscilla said, there are many things that they'll tell the social worker that they won't tell us. Even if we're in the
Mhm.
same room with the social worker, to be honest with you, they may not feel comfortable sharing because they feel as if we're going to judge them. They feel as if, it's going to impact how we give them care and everything. So I think one of the most important things is for them to realize that we're working together to give the care. I'm the expert, the content expert, in the sense that I have the medical training, but they're the expert in their child, right? And then if we realize that we're both experts, but in different ways, then that kind of establishes that trust so that they will feel comfortable telling us that they're going through, difficulties, etc. And I think the other big thing to say is that it's a team approach. The barriers to that are because somebody put in the chat about social work and child life. So in transplant, having a social worker is a mandated thing. So many times we do have a social worker. We may be sharing the social worker, but we have one. So funding is a big thing. Psychologists also, because it's driven by RVUs, which is how many, billing. Sometimes it's difficult to get a dedicated psychologist. And, unfortunately, because the hospitals are very income driven, it's sometimes difficult to have those resources. Same thing with child life. So I I think, yeah, so I think if I had to summarize, team approach, continuous assessment, and establishing the fact that we're co-collaborators in the care of their child, and we at the end of the day want what's best, and that is a good outcome for not just the child but for the family, right? Because if the parent can't work, or if the parent has their own mental health struggles related to, somebody put in the chat about trauma, and it is incredibly traumatic what caregivers go through watching their family members be sick and have chronic health needs, etc. And I think respecting that, the psychologist often worked with us to help find mental health um, counselors for the parents also, because the psychologist can't provide therapy for both the parent and the child, except if it's directly related to the child's care. So they usually will help them find mental health assistance also.
Gotcha. Thank you. And
Mhm.
you set it up very nicely for Camila to jump in and talk about the mental health and psychosocial needs of the family caregiver. And so, Camila, recognizing that you're in a different space, just want to open up the kind of it for any comment or reaction or connection to the work that you're doing from what Priscilla and Nicole have mentioned.
Yeah, Priscilla and Nicole mentioned it beautifully. I think from the psychosocial perspective, a lot of the ways in which caregiver needs are being examined are through interviews. So, spending time getting to know the caregiver. But even that is not very systematic. And so, sometimes people are doing it more on the post-transplant side. Sometimes people are doing it here and there. It depends on the centers. The resources are a big piece of it. And so I think from a research standpoint, it would be really good for us to get to a point where we can have some systematic way in which all centers are doing it. And then also a way in which we can incorporate it into part of the care so that we don't overburden our social workers, especially. And so I think a lot of work remains to be done to get this to a better space so that we can take care of our caregivers and our patients in the best way possible.
All right. Okay, so moving on to working with kind of different transplant families and communities. One of the questions that we wrestled with when we conducted our survey and learned about the findings was around kind of caregiver needs being universal or population specific. And I believe there's no right or wrong answer, but would just love to hear from each of your perspectives around kind of what similarities, and we can start with you, Nicole, similarities and differences you see across the transplant populations that you serve in populations, communities, really interested in how, we won't define that for you, but just want to pose that question.
Yeah, so one thing I will say is so my patient population is what would be considered underserved, and not in terms of nephrologists, we have a lot of nephrologists, but just in terms of the resources that they may have access to, lower education, lower, the household incomes are lower. But one thing I will say is that because of that, people, and whether it's community-based, other providers, et cetera, the society in general, makes a lot of assumptions about their ability to be able to care for their relatives. And my role is to challenge that. You don't have to have a medical degree to be able to care for your child or parent or loved one. And you don't have to, be wealthy. I think sometimes, I guess what I will say is that the application of caregiver support should not be population based, i.e., not making assumptions about the patient
Mhm.
population that you serve. It should be individualized. And that means I know that you have to have a basic framework. So we have these resources in place, but each person is going to have different needs, right? So somebody would look at me and assume, okay, she's a doctor, she's a pediatric nephrologist, so she's not going to have any difficulty getting to appointments, doing this, doing that. But of course I will, because I have a demanding job and I feel, torn sometimes by having to leave work to go do stuff. And so just because someone doesn't have, the same barriers, it doesn't mean that they don't have needs also. So I think individualizing it, but also our role as providers is not to make assumptions one way or the other, because sometimes we give a pass to people who seem like they have it all together, but you don't know what's going on beneath the surface. They're dealing with their own mental health struggles, their trauma, trying to juggle it all, perfection, whatever it is, they may be dealing with that. So I think having a basic framework with support, with what your support systems are is important, but the team's responsibility is to determine what each individual unit needs. And then I will just say before I finish that even if you have a family with two or more caregivers, so you have a two-parent household, it doesn't mean that their needs are going to be the same, right? Because you could have one who understands more, gets it more, and is more resilient, and then you could have another one who's really struggling. And I think that's also another thing that we have to recognize when we provide care. Like there's a lot of provider responsibility in this.
Yeah. And really appreciate you talking about kind of the individuals seeing and recognizing individuals for who they are, even within a family, and not making assumptions about patient or patient populations. We work with an incredible family caregiver who shared that white woman in her 50s, who's real estate agent, I believe, by profession, and she talked about kind of walking into the healthcare system and transplant. Her daughter was getting a transplant and saying that all of these assumptions were made of me, and I was having so much financial trouble, but no one asked me. They just assumed that I was okay. And her story really sticks out vividly because she talks about having I think like needing a roof and having like water leaking into her house and like having to maintain her home safe and clean and sanitized enough for family. She's like, no one asked me, and I really needed that. They just made kind of assumptions about who I was. So it's prompted me to think about that particular caregiver. Priscilla, what are some of the similarities or differences that you see across transplant communities and families that you serve?
Yeah, so I think, and I think you're touching on a couple of things that I was thinking of. One, I think it's for pediatric transplant and young adult bone marrow transplant, sometimes we have patients in the hospital for even 6 months or even longer, right? We hope that's not the case, but there's many cases that the patients are here with us for a long time due to complications, etc. And so it's really hard, right? Because at the beginning, the families are here, the parents can spend time with the kids, but at some point, I think the financial situation, kicks in. And so it's hard, and I feel sometimes we're like stuck. I think having we sometimes have 6-month-olds, 2-year-olds in the rooms on their own with the nurses, and so I think the financial part is one that we have. And I think what you were saying, Nicole, right? Like we need to be able to make families trust us and be able to share what is happening. And I think us as physicians be able to take the time and make sure that mental health and social situation is as important as, your I don't know, cardiac function or like your labs, etc. And so be able to establish that relationship for the families really to share with us what's happening. Because I feel sometimes we can find help and we can find organizations and nonprofits and some others to help us. So yes, I think financially, I've had parents that lose their jobs or moms that cannot keep working and they cannot pay for childcare. So then we have to take care of the siblings here in the hospital. So I think that part is hard. I think we find resources, but I hope we could find like a better way for, having like government support, things like that. But don't get me going. Uh, but I think, yes, establishing that relationship is important. I think for us in pediatrics is hard because we treat the whole family. And so we need the parents available. Those parents have the other kids that need their parents. So it does get difficult in certain situations. And so um, what you were saying, I think it's also important. We don't have like a standardized way of doing it in every center, which maybe if we would, we could learn more and be able to do more about it. And so that's part of the work that we're trying to do, kind of like, can we standardize things so we can learn how others work? And if somebody's doing it better in one place, can we learn from them and change what we're doing in our center to improve those situations? So yeah, it is challenging.
Indeed. And Camila, would love to hear kind of what you see kind of research in this area, and if there's any specific populations that you work with.
And so Priscilla and Nicole have talked about a lot of similarities that we see across like organ types. And so my research is primarily with adults. And so thinking about like the financial burdens and mental health needs, adjustment, there are a host of things that are going on. We also do see that there's some specific things that may be required of depending on organ type. So, for example, somebody going through a lung transplant, they may have the caregiver may have to learn about certain ways of helping the patient that are require a little bit more training. Relative to kidney. And so even with that, you're still having a caregiver who has very similar needs, but they may be a little bit augmented depending on the organ type, and also the population, right? So Priscilla and Nicole have talked a lot about like family. So if your family member who's a caregiver for a child, you're dealing with multiple levels of things, right? You're already a caregiver, and then you're dealing with another level of caregiving in terms of, having a child who is sick and needs additional care. And then just wanting to echo a lot of what has been talked about in terms of us thinking about standardization, but also thinking about tailoring care, is very important, because we do have different needs depending on the individual. And, somebody in the chat talked about cultural humility. Terms of, especially as providers, being able to realize that, and Nicole talked about that, like the patient is the expert of their life, right? And so having some humility and sense of, I may not understand everything. I got a lot of knowledge in one area, but I may not understand everything. And so being willing to learn and show the patient that, I think it can be helpful when your provider is modeling the sense of, I don't know this, and I'm going to learn it with you too as well.
I really appreciate that kind of framing of standardizing. And now we talk about we want a standardized caregiver support program, but both all of you have spoken about the importance of tailoring that to specific families and accounting for family dynamics or diverse populations and not making assumptions about those populations. And then, of course, like health equity considerations, cultural, linguistic, considerations that are showing up or that folks are bringing up in the chat. So thank you. Yeah. So moving on to the support programs and services, our research shows that most centers offer some support, but that support is really varies considerably. Talk about, so Nicole, from kind of what medical or care coordination responsibilities are transplant caregivers managing that your current support model or the work that you're doing as a clinician is designed to address? So it's a couple of things. It's like what are wanting to get a better understanding of like the medical and the care responsibilities within your space, and then the programs and support services that you're providing to address those responsibilities.
Okay, if I understand. Okay. So in terms of I would say I'll talk about pediatrics and adult.
Mhm.
So pediatrics, I think the things that we keep we keep track of are obviously medical. So that's the transplant providers, the physician, the nurse practitioner. Then school is a big thing.
Mhm.
So are they going to school or not? How are they doing in school? The that is going to be physician, social worker, and psychologist as needed, but the usually the psychologist involved there is going to be from a developmental behavioral psychologist or for neuropsych. A lot of our patients have cognitive impairment, just related to a lifetime of chronic illness. So trying to recognize that as early as possible and refer them for neuropsych evaluation so that they can get the appropriate services that they need, because just saying that you're in school but you're failing everything or you can't read or write and you're 10
Mhm.
is not helpful. So trying to get them the services that they need. Their mental health, that's going to be a psychologist. Um, so that's for the patient. For the parents, the checking in with them, how are they doing? That's going to be social work with the transplant provider. Then also a big thing for a lot of our patients, not a lot, but several of our patients is housing.
Mm.
and whether the housing is safe in every way imaginable.
Mhm.
And there is both our social worker, but then there's also, and I forget their exact title, but there are persons within our health system that can help them with not necessarily finding a place for them, but putting them in contact, because this is usually for persons who have public housing, putting them in contact with the necessary persons to help them with the application process. I'm in New York and it's a very tedious process. So helping someone navigate, especially if you have you know, poor literacy, is going to be difficult to complete all of those forms. And then also if the parents themselves have any specific mental health needs, we help to refer them. And lastly, also job. Um, it's very mixed who work and who doesn't. Like was mentioned, it's very difficult to work if you in any job, but if you're particularly in a job where, you know, it's an hourly wage, minimum wage, it's etc., it really, really is difficult to maintain a job if your kid is always in the hospital or your relative is always in the hospital. So, you know, we do if the parents are employed and are able to maintain that employment. I don't wait to tell them, wait until something happens to be like, you should have applied for FMLA, you should have done this. If I know that they work from the time that the kid is diagnosed, I mean, I say kid, honestly, this is the same for adults. Be like, you need to apply for FMLA, you know, and this is what you need to do because you don't want, and they're like, no, my job understands. And I'm like, they understand for now, but they're not going to understand forever.
Mm.
And you need to do it now so that it's on the record and nobody can say that you have excessive absenteeism, etc. So really trying to pull from all of those areas and use the different members of our team. I hope I answered that question completely.
You
Uh,
did, and I
yeah.
appreciated the going back to kind of the work that I presented in terms of health-related social needs, transportation, housing,
Yes, transportation is
employment
the other one. Yes.
are the ones where we saw less of the transplant centers that we survey were providing those less. So it's really good to hear your comprehensive approach to addressing that early and forecasting perhaps a little bit for patients and for the parents about like, you know, it could be an issue or I've seen this be an issue with, you know, so many other of my
Right.
patients.
And if I just may say, sorry, because you said transportation and I forgot. So that is something that sometimes like they don't tell you and you make a lot of assumptions, right? So
Mhm.
parking, you know, I'm in New York, parking is expensive. And, you know, patients sometimes we don't know unless they tell us. And so that's something that I realize we need to do better. How do you get to appointments? And I'm not saying that they don't tell the social worker, but things change over time. So that kind of ongoing assessment. Because then one day mom said to me, you know, I'm coming here every week and this is a lot of money. And I'm like, I assume that she took transportation, right? And so then I was like, I'm so sorry. We never clarified that. And this was a pre-transplant patient, but she was coming so frequent. So I think, um, yeah, that kind of ties into that ongoing assessment because things change.
For
People
sure.
get jobs, they lose jobs, etc.
Okay. Yeah. And Priscilla, what are you seeing in terms of the patients and the families that you work with in terms of like the medical and care coordination that is expected or required of those family caregivers, and how are those responsibilities being kind of supported or addressed through your programming and services?
Yeah, I think it's, you know, I always think of everything they have to cover and I always tell family, you know, like I don't know how you're doing this, right? Because it's like a huge list of responsibilities. I think we have established a very good, and I think maybe Nicole, that's what you were looking for, the word, like a care coordinator. So we have what we call care managers or care coordinators, and I think we also have assigned each family or each patient to one of them. So it's like a consistent person working with them and gets to know the families. We have a very direct contact. I guess nowadays with technology, you know, there's like a lot of like emails back and forth rather than like waiting for the phone call to be gotten back and those things. So I think that has worked. And usually the care coordinator also has, like, the family has a social worker assigned to them. And so we try to make sure it's not like, you know, somebody that is just rotating, to make sure that they know the families. They get, you know, at the end of the day, it's a relationship that you build with the whole family, and so getting to know them. I think similar as what Nicole said, kind of all of those, transportation, lodging, financial, etc. We also try to involve them in like support groups since the beginning. So we have support groups during the hospitalization that happen maybe like once a week. And it's like kind of something informal, but the feedback we have gotten from patients and families is that, there's Facebook groups and there's all of this, but like it's hard to really connect. Sometimes it's out of fear, right? And like building this emotional connection with other families that you don't know what's going to happen later on. But we have kind of like informal meetings where it's just like open to patients and families. Usually it's more like the caregivers, right? Because the patients are in the rooms, but just for them to go and grab a coffee and maybe be able to like talk to somebody. Sometimes the social workers are there as well, just kind of like to try to build a little bit of like community and make them as more, comfortable. And then we also have different organizations, kind of nonprofit, that are available to try to, see if there's any needs that they could meet for patients. They help us sometimes with lodging. They help us with some financial needs. And then we have opened now like a monthly online meeting for patients that are post-transplant, because we don't realize how much, well, we do now, right? But like I feel sometimes you are post-transplant, you're good, but there's so much needs that are unmet, so much financial troubles as well. And so we're doing monthly Zoom meetings with patients and caregivers. And, there's like a topic each month, or people can just bring up kind of concerns and ideas. And I think that has been helpful. Like we've gotten good feedback. This is kind of new, but I think what they were, what I've been reading in the chat, like we need to change the culture so physicians and families are, just working together. Before I forget, we also have, and we're trying to get that to other hospitals. We've done some research on how much like animal therapy and child life helps. I know this is more pediatric focus, but we have shown that it's just like how much that emotionally can help. And I would say pediatrics, but we have young adults, 25-year-olds, 30-year-olds, and like it's a big help to have that available as well. So yeah, I think that's what I have to add.
Yeah, thank you so much. And just want to share that from the survey that we did, and we surveyed what kind of programs are available. Overwhelmingly, we hear from like our partners, particularly patient advocacy groups, where like we need to increase the peer support. And from family caregivers who tell us like there's nothing like being in a room with other folks who are like in a very similar boat as we are. And just having like know what it is to manage all of these things. And not only that, as a listening, as a coping, but also to say like we've had caregivers share like the best kind of tips or advice I've gotten them from someone else who was in my shoes and was like, this is the resource that you need, or this is the resource that you will need, like in X amount of time. So appreciate that. Camila, I'd love to bring in your research lens here, and which caregiver support interventions or programs appear to make the biggest difference in practice, and kind of what evidence should we be paying attention to?
So I think again, this is an ongoing problem that we don't have a lot of research in this area. And Knack and you, Yadira, and your group, you are doing a lot of work to kind of close that gap, right? Um, I've seen some research where people have created different psychosocial interventions, so kind of like some mindfulness-based interventions, mindfulness training where, you're learning to be like more present, and attuned with what is going on in your life. And then also I've seen some interventions where people have done some stress management. And so obviously all of those are important, but again, we don't have a lot of work to know what is the best practice. And especially as a lot of you've talked about, coordination and support groups. I know like a lot of programs have support groups. Some of them may be informal, some of them may be more formal. And then sometimes these are kind of like ad hoc. So a lot of the research just is very limited to really understand what would be most effective. I think most programs are doing a lot of good work, or doing the best they can with the resources they can. But we still need a little bit more to have an idea of what would really be most beneficial.
Thank you. And so this is a good segue into the last question before we open it up for our audience to ask questions. And is looking ahead, what caregiver support needs or service gaps deserve greater attention from transplant centers? And I will start with you, Priscilla.
Yeah, so I think from my personal experience and like our team here, I think lodging it's a really hard one. I think and even in this transition from young adult to adulthood in pediatric, I think we really struggle for lodging. With families, transplant centers, you don't have them everywhere. And so we have a lot of patients that come from like rural areas or referred from other centers that need kind of higher care. And we have a great help from like the Ronald McDonald House, for example, but it's gotten that it's not kind of enough. And so I think lodging is challenging. They need to do like background checks. I just had a family that we had the 16-year-old here for, I think it was 2 or 3 weeks before we could get a place for the mom to stay with another kid. And so I think that's something that we struggle with quite a bit, and all the requirements, eligibility, etc. And so something that we're trying to work on and see, is there something else that we can work around this.
Such a big need in general, but with the added layers of needing medical attention and getting a transplant. Yeah. What about from your perspective, Nicole?
Two things I think are other family member support. In pediatrics, I would say sibling support. And the reason why I say that is because I know that parents uh, or caregivers often feel a lot of guilt about neglecting other family members because the one who's sick becomes a priority naturally. And so I think I don't know how it will be accomplished yet, but I think there are some centers I know, especially in the oncology sphere, have sibling support groups. And so I do think that trying to figure out how best to support, those other immediate family members, and usually it's siblings outside of the parents. It's usually siblings is very important. The other thing, I think, is unique support for parents when their children are transitioning, because that's also a very difficult time for them emotionally. A lot of them really struggle with it because, they have been the person for so long, and then suddenly they're being asked to leave the room, and we have to talk to your kid first, but they don't trust the kid. And, to make to make, health changes and everything. So I do think that supporting them, and if you go with the lens of where, raising a child to be independent is the goal of parenthood, usually they're a little bit more receptive. So it's not like you're no longer involved, but we want your child now to be a co-partner like a co-collaborator. So we're bringing on more collaborators, and your child is now a collaborator. Before they were just a participant, but they're a collaborator. So I do think that that those are two areas that would be you know, helpful to be developed some more.
Yeah, thank you. You remind me of another. We've worked with a great group of family caregivers of someone whose son received a transplant, and she talks about the emotional like strain and toll of kind of recognizing and navigating the fact that her son had to go to college, but then also because of the distance of her not being there to support the care coordination, the health decision making, and kind of working herself up to be like, this is okay, like this is a new role. But then when, unfortunately, they had a medical emergency and it just kind of, it was a lot of emotions to navigate. Uh, that particular situation where she ended up saying something like, I've recognized now that I'm always going to be his caregiver. Like
Hmm.
I come to terms that he's an adult and he's growing, but like I will always be his caregiver because of this certain medical situation context. Yeah.
Yeah, yeah, no. That's a big thing is when if the child expresses a desire to go to college and the college is not, they can't live at home because of the location of the college. Usually they try to have us gang up with them to tell the kid that they can't go to college. Which we say, well, I never said that, but yeah, helping to prepare them for all these transitions, whether it's physical in terms of moving away or just a different care model. Because there's also a lot of, if I just may say it really quickly, a lot of anxiety also about transitioning to the adult side because they do I think somebody mentioned in the chat, things are done differently. They're a lot more patient. So they may not have the same personal relationship with the social workers, et cetera, that they do on the adult side. But recognizing that because that care model is different, it doesn't mean that it's, worse. It's just different, and we will help you to navigate that change.
You. And Camilla, you get the last word before we go into the Q&A with the audience. And it's the question again is looking ahead, what caregiver support needs or service gap deserve greater attention from transplant centers?
I think my biggest thing is I think we need to look at caregiving in terms of um, from pre-transplant, during transplant, and post-transplant, right? And recognize that it's an ongoing process, but it may differ depending on where the patient is. And so I think being able to think about, okay, so from the pre standpoint, maybe what some considerations we may give is what how will we define caregiving? How may it look different depending on the family dynamic? So we can't have this rigid way in which we assess caregiving. And then during the process, what services can we provide? What can we do? For example, also depending on the family, there may be some religious needs or cultural needs or language needs. And then post-transplant, what can we provide so that, people can still have caregivers can still have that care, but also training. It's to be put in this role, you may need some training to know what I need to do, what to expect. And I think the caregiver training that we have, it's not very comprehensive a lot of the time because of limitations in terms of time, but also in terms of resources.
Okay. Yeah. Lots of nuggets there. I we're going to do a bit of multitasking. We're going to pose the question for the audience in the chat, and I'm going to queue up the questions for our panelists. There's already some that have come in. So if Lauren, you can add the question about, uh, in the chat, which is thinking about everything that you've heard so far, what caregiver support services would have the greatest impact if available at transplant centers? So it's another version of what I just asked the panelists, but we want to hear from you who have joined us in the call. So if you can answer that question, that would be lovely. And I can get us started. We can answer a couple of questions that have come in through the Q&A. Let's see. First one is very interesting, and I'll just post it, and you all can just post it to all of you. But it is regarding barriers being perceived, not structural. How do you perceive how dads are accepted in their role as a caregiver?
Um, we, this is for us to answer, correct?
Of course, yeah. That's
Oh,
for
okay.
Nicole, Priscilla, and Camila. Yes.
Yeah, I mean, we have both of, I mean, overwhelmingly the moms are the ones who come to the appointments. I will say probably, well, I think it honestly, we have no problem with, we welcome dads and moms,
Mhm.
into the care. Sometimes, one parent does have more responsibility for knowledge of the medical care in terms of medications, etc. And so whether it's the dad or the mom, because it varies, we just want that whoever, that we can speak to a parent who has a knowledge of the child's health care. And sometimes that means calling on the phone. So if the person accompanying to the appointment is the father, but the mother knows more, that's okay. If it's the other way around, that's okay too. It for us, it doesn't matter. There's no minimization. I guess, there are things on social media that do, poke at dads not knowing what's going on and stuff like that. So I'm wondering if that's where that question comes from. But in our clinic, we have both, and it doesn't matter. There's no discounting or minimizing their role in the care.
Thank you. Unless Priscilla or you, Camila, want to add, I'm going to turn this Q&A into a quick fire chat so that we can get more questions. But okay. So the next question is around, in transitioning adolescents into adult care, often I see parents whose transplant kiddos have developmental and neurological impacts due to their journey. In my survey of heart transplant parents, no parent rated their child's function above 70%. How often are there evaluations to assess care readiness of these kids and discussing guardianship to maintain appropriate care? And I'm guessing this is for you, Nicole or Priscilla.
Oh, okay. I can answer, yeah, I can answer really quickly. I would say one of the other unmet needs is the availability of neuropsych services and testing. Because in order to get guardianship, so we do pre-identify and discuss if we think that the young person would benefit from guardianship, but they have to be tested in order for that to happen. And the wait list for testing is incredibly long. The only way to circumvent it is to pay out of pocket, and it costs several $1,000s, which most people cannot afford. So that is something that we have met as a barrier to establishing guardianship. And I will say that one of the things is that a lot of people wait until they're, you know, 17 and 10 months, and that is honestly too late. It should really start probably 2 years before because it is a lengthy process. It's not me signing a paper and saying you need a guardian. It's really, I participate in it, but it requires a lot of paperwork.
Mhm. Okay.
Yeah, and I'll just add, I think we also, this is a huge waiting list. We tried to do this like a year after transplant, and I started looking at these assessments and kind of go from there. I think organ transplant might be a little bit different in how it affects, kind of more like cognitive development, etc. But usually at a year, and you can repeat every year.
Gotcha. Thank you. And this next one is it starts off with a comment and it's said, thank you for all of the work that you do. I, as a patient that has dealt with chronic illness since childhood, I have seen my family suffer from PTSD. Uh, Nowhere along the way did anyone reach out to them to ask how they were coping after my transplant. How do you feel that that could be improved? And the person in the chat says, even though my transplant was extremely successful, my mother can talk to me about the past because it's so difficult. It was so difficult to get where I am now. And given the mental health, psychosocial aspect, wondering if you can take this one on, Camilla.
Yeah, that's such a great question, and thank you for sharing that. I think this is a very important issue that we need to deal with. And it goes back to what I was talking about in terms of, I think we need to have programming for during and post-transplant. And if we have more of a comprehensive way of assessing caregiver burden, and caregiver needs, this is something we could catch and potentially refer people for services or have some support group or some group therapy or something. And so I think in a case like this, if this question is just really emphasizing the need for us to have just more comprehensive services to be able to get to caregivers as soon as we can.
For sure. Thank you. And with that, that's the last question. I do want to share that we are planning a listening session with transplant and cancer caregivers at the beginning of October, and so be on the lookout for that. And in terms of a closing message, just want to share that this conversation has really put in perspective from NAC's perspective. We don't believe that, it's no longer a question of whether family caregivers really matter in transplantation. It's how do we build systems that really recognize, assess, and support them as essential partners in care, support them in the work that they're already doing. And so I really appreciate Camille, you, Nicole, all of you, Nicole, Camilla, and Priscilla for joining us today, for talking about some of the incredible work that you're doing, some of the challenges that you're working through, that are really important to meet patients and family caregivers where they are at. So really appreciate our panelists and all of you all who joined us. And then if I can have, Mike, if you can pull up the last slide. Just want to make a quick note that the work of the collaborative, including this great forum and this group, this panel, conversation with the panelists would not be possible without our funders. So thank you, Biogen, Sanofi, and Takeda. I encourage you all to be on the lookout again for our October event, and then also to sign up for our newsletter and hear what we're up to in terms of really getting family caregivers and transplant recognition and support. So thank you for joining us.